He's got enormous, he provides enormous help to all our patients who have type 1 diabetes, helps them to technology. And I would say he's made it simpler and easier for people in India.
Oh, that's wonderful. That sounds great.
And Zalak is our backbone of this whole program for this year and for next year. So I haven't mentioned anything about Zalak.
Ma'am, we are good to go.
Yeah.
Yes. Thank you so much. So, good morning, everyone. Today we are here. We are here today for the ISPAE ACES meeting. This is a 26th series of ISPAE ACES, that is Academics and Clinical Education series. And today we have the theme of technology in type 1 diabetes. We have a case presentation this time and a talk further on technology, and then we'll also see the Indian context. So before we move further, I would like to invite Dr. Ahila, our president of ISPAE. Over to you, ma'am.
Good morning, everyone. Thanks for joining us on a Sunday morning. It's a pleasure and a privilege to be here. We welcome all of you for this edition of ISPAE ACES meeting, and we've got some wonderful educational material in this meeting, and we hope all of you benefit and take this care further to our children with type 1 diabetes and improve their care. So we've got Dr. Mohana, Dr. Harsh, Mr. Harsh Kohli, Dr. Professor Ben Wheeler, and Dr. Saurabh. It's a pleasure to invite Dr. Saurabh Uppal, who's a pediatric endocrinologist from Jalandhar. He's got enormous work, or he's got enormous interest in improving the healthcare of children with type 1 diabetes and his deep interest in technology. And he's been able to make us understand the intricacies, because our technological use is far, far lower than the rest of the world. And he's got his MD, DCH and MRCPH, and also his fellowship from Manipal, and further some post-fellowship training abroad. Welcome, Dr. Saurabh, and the floor is yours. All the best. Thanks.
Thank you, Dr. Ahila. Thank you for the opportunity and the kind introduction. It's a pleasure to be here. It's a pleasure to be here with all the ISPAE members. And in fact, with you, I am also excited because we have a very educative meeting lined up. So we'll start with a case presentation by Dr. Mohana, who is a fellow in pediatric endocrinology at the Aster Hospital in Bangalore under Dr. Kavita Bhatt. And followed by that, we'll have lectures by Professor Wheeler and Mr. Harsh Kohli. So I would request Dr. Mona to please start sharing her screen and start her case presentation. We'll take questions at the end of the case presentation, but in between, if any one of you has any queries, please put your questions in the chat box and we'll take them together. Dr. Mona, please.
Thank you, sir. It's okay. One second, sir. There's some problem with my network.
Dr. Mohana, if you have any issues, can you just, in case you want my help, can forward the slides to me and I can run the slides while you talk.
Yes, ma'am. Okay, ma'am. Yeah, ma'am, I have some issue. It's not running properly. I'll just share these slides with you, ma'am.
You have my email ID?
Yeah, can you just share? Click on the first slide and then press share, the present.
Or if you have Saurabh's number, you can share it with Saurabh, and Saurabh will send the slides for you.
Yeah, okay.
Can we do it in the, can we send it to RX event?
Zalak, I think you've got two devices on.
I'll share. You just try once more. Try once more.
Yes.
Yeah, please try once more.
Send it to me in chat box. I can share.
I'll just share this to you, sir. I'm so sorry for this delay. I think some problem.
Saurabh, if you have a copy of our slides, can you share?
Yeah, ma'am. Sir has a copy.
I have a preliminary copy. Mohana, you can add all that we discussed later. So I'll start
Yes.
sharing. I'll start sharing.
Okay, sir.
Don't worry, Mona. That's all right. It can happen to anyone.
Yes,
Just
ma'am.
relax. That's fine.
Okay, I'm sharing your slides.
Okay, sir. So please wait, sir, not this one. I have recently shared you another, this one, sir. Yes, sir.
This-
Thank you.
this one.
Yeah.
Wait, I'll just make it widescreen. Yeah. Is it visible to everyone?
Yeah, it's
Yeah.
working perfectly, Saurabh. Thank you so much.
Okay.
Good morning, everyone. I'm Dr. Mohana. Today, I'm going to discuss about a child with type 1 diabetes mellitus who was diagnosed with JIA. Next slide. Uh, she is a 12 years, 9 months old female child who was diagnosed with type 1 diabetes mellitus in August 2022 at 11 years, 5 months of age. She was initiated on insulin pump 780G from April 2023, which is 8 months after her diagnosis. In September 2023, that is first week of September 2023, symptoms suggestive of JIA, juvenile idiopathic arthritis, were observed with on and off flare-ups in the form of increased joint pains, and skin biopsy of the rash confirmed diagnosis of juvenile idiopathic arthritis. So treatment started from 21st November in the form of oral steroids, which were initially 5 mg once in a day and which was made later BD dose. In view of raising blood sugars, she was referred to us for glycemic control. In the past history, she was diagnosed with diabetes mellitus when she was admitted with severe DKA. Initially, she was started on insulin aspart and insulin glargine. Later, she was transitioned to insulin from last week of April 2023. Her HbA1c during diagnosis was 15%, and just before transition to the pump was 8.4%. Her birth history, she was born to G3A2 mother at full-term gestation age through lower segment cesarean section, birth weight being 3.4 kgs with no perinatal complications. Immunization history was normal. Her developmental history was also normal. Her family history showed autoimmune disorders in the family with father and paternal grandfather both having psoriasis, which was diagnosed at 30 years of age. Mother being hypothyroid, which was diagnosed at her first pregnancy, and she's on medication. Next slide. In examination, child was conscious, coherent, and in no distress. Her vitals were stable. Her weight was 40.6 kg, which fell in between 25th to 50th centile. Height was 147 centimeters in the third centile. BMI was 18.8 kg per meter square, which fell between 50th to 75th centile. Systemic examination was normal. Her SMR staging, sexual maturity rate scaling, fell in Tanner stage 3. Both breast and genitalia fell in Tanner stage 3. This slide shows her transition phase after initiation of insulin pump. In April, just after initiation of insulin pump, her HbA1c was 8.4%. In September, that is 5 months after initiation, it was 7.1%. After initiation of pump, the child quality of life of child and parents both reportedly improved along with improvement of glycemic control. this is slide where I wanted to show before the initiation of steroid in November, where her time in range was about 82%, with her total daily dose being 37.3 units, her autobasal rate being 32%, and carbs entered were 340, with active insulin time was 3 hours. This usually I kept it for showing her meals being 5 to 6 times per day, along with the bolus wizard. Next slide, please. So during treatment with steroid, that is from November, which where initially she was started on 5 mg per day, later made BD. In December first week, she was admitted for intraarticular and intravenous steroids due to flare-up. After initiation of steroids, increase in appetite was observed, and her insulin carbohydrate ratio, which was same like 1:15. In view of persistent hyperglycemia, only feasible option was giving bolus by entering pseudo-carbs. Here we can see the image. This is during the administration of intravenous steroids, where her glucose was ranging high, above 250, and the pump started giving auto corrections at about 10:45 a.m. But it stopped at about 12 p.m. Even though her sugar was high, it stopped giving auto corrections. Next. This is the later week of the November, where she was started on omnacartil 5 mg per day initial dose of steroids. Her time in range drastically fell from 82% to 68%. Her total daily dose raising from 37 to 47 units. Autobasal raising from 26 to 28%. Meals per day or increased from 6 meals to about 8 meals, and carbs entered raised from 340 to around 439. Her active insulin time remaining same as 3 hours. This is her ambulatory glucose profile showing the data. Next slide. So this is the log which I collected, showing her glucose recordings reaching above 400 during the period of intravenous steroid, that is on 7th and followed by 8th. Followed by 8th December, where it was above 400, and there was increase in basal rate. Even then, there was no correction up to the in the normal range. So this is omnacartil, where it was increased to BD dose, and also intravenous steroids, which it was administered, where her time in range fell gradually from 58% to 54%. Her total daily dose increased from 47 to 57, and auto correction and autobasal and set autobasal rate increased from 28 to 30%. Here we can observe she started changing set change every 5 days, and carbs entered being almost the same, 439 and 417, around 439 and 417 grams. Here we can see her meal boluses increased from about 5 to 6 to even 12 on some days. This is during her transition period from parenteral steroids to back to oral steroids, where her time in range was from 54% back to 58%. Her total daily dose increased rapidly to 87 units, with carbs entered being the same and autobasal almost being the same. But here we can observe a change of set change, which she made every 2 days. And her active insulin time, we changed it to 2 hours. So interventions we changed in this child are insulin carbohydrate ratio, which we decreased to 1:10, active insulin time, which we reduced to 2 hours. So by reducing the active insulin time, insulin carbohydrate ratio, though initially the initial period from initial week of transition from parenteral to oral steroids, there were high glucose recordings, which time in change as we saw as 58%. Within a week, the pump algorithm helped to improve glycemic control. So this shows that active insulin time being one of the most important change that helped the pump algorithm to improve glycemic control. So this was the slide I was talking about. Within a week, that is from up to 14th, we observed her time in range was about 58%. It drastically improved to 89%. Her total daily dose was reduced from 89 units to 76 units. Auto basal being increased to maximum range, like it was about 30%, now it's 36%, with almost the same amount of carbs, like gulp amount of carbs, and her active insulin time being 2 hours. Here we can observe that sustain was done in every 4 days. So this is the overall report which we observed. Her time in range initially after starting steroids, it gradually fell down, but when her insulin time was reduced to 2 hours and her insulin carbohydrate ratio reduced to 10 units, we can observe that her time in range again increased, with auto basal reaching the maximum range to 36% here, with even with almost gulp amount of carbs like 449 grams per day. Next slide, please. So, coming to the discussion, steroid-induced hyperglycemia. Actually, it depends on duration and type of the steroids. Usually, in intermediate and long-acting steroids, we observe this hyperglycemic recordings. Intermediate acting steroid, though their peak action lasts for 4 to 6 hours, but if they are given in divided doses, they can cause hyperglycemic events, like prednisolone and methylprednisolone given in this child. Next slide, please. So what is the pathophysiology of steroid-induced hyperglycemia? It increases gluconeogenesis by antagonizing action of insulin. It inhibits production and secretion of insulin by pancreatic beta cells, decreases uptake of glucose by adipose tissue and skeletal muscle. It increases expression of nuclear receptor, peroxisome proliferator receptor alpha. This is an at cellular level where it increases gluconeogenesis and decreases glucose uptake, causing hyperglycemia. It increases effect of glucagon and epinephrine. It is all synergistic in thing, synergistic in action. So all this contribute for hyperglycemia in children with steroids. So today I'm going to briefly discuss about insulin pump, our main topic here, which is 780G, minimum 780G pump. So it acts like an artificial pancreas. It works on hybrid closed loop system. It integrates continuous glucose monitoring with insulin pump together with an automated algorithm which controls insulin delivery. It has Guardian Link 4 transmitter and Guardian Link 4 Guardian Sensor 4. It also has this feature of AccuCheck guide link meter where it pairs with the pump and sends blood glucose recordings to the pump. Insulin reservoir, which will be about 3 ml. Till now, studied insulins in insulin pump 780G are insulin novorapid and Humula, which are Aspart and Lispro. So this is a brief model showing how the pump will be placed on the body. This is CGM with transmitter, which transmits sensor glucose data to the pump. This is a receiver along with the display monitor where we can manage the insulin delivery system. This is the insulin patch and insulin delivery system. So Minimed 780G, it automatically determines basal infusion rate all the day. It gives the option of usually initiated meal boluses. It has automated correction bolus function. This is a display screen of 780G where we can see this magenta color being the basal insulin. These blue lines being the auto correction boluses which the pump gives. This or vial sign which we are seeing is the bolus amount which patient has taken, which can be meal or correction. This blood drop being the BG or blood glucose entry that has been made. This green band is the desired range, that is green band. These blue line are the SG recordings which are shown over time span. When we can tap anywhere over this blue line, it will show the time and SG recording at that point of time. This green band with the person running sign is a temporary basal target range, which we can set whenever the person is going into physical activity to prevent hypos during or after physical activity. This fork and knife sign is the carbohydrate entry made at that point of time. So this is the graphical description of the how 780G pump works. So we can select the range default setting of 100 or 110 or 120 basal rate. This basal insulin, which is magenta colored, adjust every 5 minutes based on the sensor glucose recordings. This blue lines gives the auto corrections whenever the sugar start raising, which default rate we can default rate is 120 mg per dl. It gives auto corrections every 5 minutes to prevent highs. And these auto corrections may also be like adjusted and when the maximum basal is reached. It also self-adjusts the auto basal rate and also auto corrections based on if predicted, based on the predicted ST readings. These are the main features of 780G pump. When the SmartGuard technology is switched on, SmartGuard technology automatically delivers basal insulin and auto correction doses every 5 minutes based on sensor glucose recordings. It helps in preventing highs and lows. How this is a basal insulin which will be delivered every 5 minutes, and auto corrections, as I already mentioned, above 120 mg per dl, it automatically gives auto corrections every 5 minutes to prevent highs. And when it suspects low, that is the glucose is going low, the auto corrections are switched off, and also the basal insulin sometimes switched off to prevent lows. These are the main features of 780G SmartGuard system with meal detection technology. This is the display screen which delivers the bolus, where it will be self-adjusting the bolus based on active insulin detected. If the active insulin detected amount it mentioned itself and delivers the bolus less when less, or when the active insulin time is equal to the bolus administered, it sometimes delivers nil bolus also. And also suspected hypoglycemia, it adjusts the insulin and delivers the bolus. So this is the graphical form I was describing about the suspected hypoglycemia. If later the suspected low glucose is predicted, this correction bolus which it was about to give, it self-corrects and gives less bolus amount. It has many features like alert systems for alert before high, alert on high, suspend before, alert before low, and alert on low. It has an alarm. Suspension at low and suspension before low are the main features which help for preventing hypoglycemias. So these are the modifiable factors which we observe in 780G: insulin carbohydrate ratio, active insulin time, and blood glucose target. Active insulin time is the time which the pump knows which time to use in calculating the amount of active insulin to subtract before estimating a bolus. So insulin sensitivity factor is self-updated by the algorithm based on insulin delivered in 24 hours. Missed meal boluses is the missed meal corrections, which I'm going to discuss, where system detects missed meal bolus if patient or the child forgets to give bolus before a meal. The algorithm suspects that there is a meal happening, and it increases the bolus amount or correction amount to prevent hyperglycemia. So this is the amount. This is a stronger correction bolus which pump automatically recognized a meal and delivered it through the pump. This we call it as missed bolus forgiveness. So though there are many features of pump like correcting auto corrections, so giving auto basal rate, suspending before low, suspending at low, though it has few limitations like auto correction bolus stops when the total correction insulin delivered in 45-minute period is more than 8% of total daily dose. This pump needs warm-up period of 48 hours before initiation. That is, whenever the new pump is initiated, it needs a 48 hours time which where the pump stays in manual mode for learning the algorithm, for learning the insulin requirement of the child. And if the pump is not used for more than 2 weeks, this 48 hours of initiation is required. And if it is not used for less than 2 weeks or any period of time, 5 hours of initiation period is required. Sensor needs calibration, like sensor needs blood glucose recording at least every 12 hours. If sensor glucose is outside, like 2.8 millipounds per liter, which is 50 mg per dl, and 400 mg per dl, this SmartGuard feature is not available. It gives up. It cannot give basal or auto corrections according to the requirement. So now here I want to say take home messages.
Can you share your slide
Yeah,
to
sure.
slides and
Yeah,
give the take-home messages?
Yeah, sir, please. So the Minimet 780G is a pump with advanced hybrid closed loop system which improves quality of life and glycemic control of the child, as we are seeing in our daily basis. Is features of auto basal and auto corrections help so much. As we saw in our child, the total daily dose increased gradually with increased auto basal rate and auto corrections. Things like set change also played an important role. By changing active insulin time, the glycemic control is ensured even in extreme conditions, as we observed. The active insulin time, when it was reduced to 2, and total daily dose increased with auto basal amount increased gradually to its maximum of 36%. We observed that even in extreme condition with that amount of carbs with steroids, child's glycemic control increased and her time in range increased to 89%. Thank you so much. Thank you, Saurabh sir, for sharing my slides. Sorry for the inconvenience caused.
That's okay. So, in case there are any questions, please share them in the chat box. You can even unmute yourself and ask the question if you want. And in the meantime, as everyone types in their questions, Dr. Mona, would you like to, for the benefit of the audience, like to summarize the interventions and how you think the algorithm has converted those interventions into good control?
So I want to show this slide for summarizing interventions we have done. So, when the intraocular or intravenous steroids were started, her time in range, the glycemic control drastically fell down to 54% of time in range. Her average glucose recordings, blood glucose recordings reached 310, around 310, and her bolus amount was about 40, which is 70%. And carbs entered were about 400 grams, and active insulin time was 3 hours. We changed her insulin carbohydrate ratio to 1:10 and active insulin time to 2 hours, where her algorithm took time to increase her auto corrections and auto basal. So it gradually increased the auto basal with increase the auto basal, which helped a lot for the pump to increase her glycemic control. With her blood glucose recordings, as we can observe here, it gradually reduced and almost reached a normal range, with a time in range maximizing to 89%. So here I would like to say that the pump may take time. Once it starts to learn her changes, it maximizes auto basal delivery with appropriate corrections. It is making on a daily basis. It works best. It is the best thing which we can observe for maintaining the glycemic control even in extreme conditions. So what we need to do is give some time to adjust for its adjust, and what we have to ensure is that her sets change is done appropriately within 3 days. Her active insulin time is appropriate, her meal time. So maintain her carbohydrate intake appropriately. So all these features will help the pump to understand her algorithm and understand her intake, understand her insulin delivery. It works best.
Just one question.
Yes, ma'am.
Ben, so why did you change the sensor patch every 4 days?
We need to change. Actually, the ideal time for changing sensor patch is 3 to 4 days, ma'am. Initially, child was changing it once in 2 days. Later, it was like once in 5 days. When it was optimized like 3 to 4 days, we observed these changes to be much more appropriate.
Are you talking about the sensor patch or the delivery system?
Both, ma'am.
Isn't
Set
it 7
change.
days for a sensor?
Yeah, ma'am. Sensor, yeah, 7 days. Set. I'm talking about the set change, ma'am. Insulin
Okay.
delivery set change.
Okay, thank you.
So you want to summarize that one, if we are intelligent with our carb meal corrections and with our active insulin time, we can enable the algorithm to work better in a
Yes,
challenge.
yes. Yeah,
Right?
we have to be cautious. We should not take advantage of the pump thinking that it gives Mr. Meal corrections and we need not give those boluses and all. We have to deliver enough boluses, enough. Have to like ensure pump knows every meal what we are taking, the amount we are taking, so that the algorithm learns best from us.
Saurabh, there is a question in the chat box.
Yes. So there's a question by Dr. Kavita Bhatt. What about the risk of DKA in the interval that it takes for the pump to adjust?
So
You realize that there can be a risk of
yeah,
DKA,
there
right?
can be risk of DKA. Yes.
So how would you take that? How would you approach that situation? Would you just give the pump some time, or would you like to step in and do something?
Yes, sir. We have to intervene. We can't just ask pump to just self-adjust. Even these high recordings like 400 has the risk of DKA in a meanwhile.
Yes. So you would intervene both
Yeah,
depending
we
on how
have
you.
to.
Yes.
Yeah,
Yes.
we have
Not-
to intervene.
yes.
Saurabh, time for the next part.
Okay. So Dr.
And-
Mona, can you stop sharing your screen?
Thanks,
Yes.
Dr. Mona. Thank you.
Okay.
That was a good presentation.
Thank
That was
you.
a very thank you, Dr. Mona, for a very painstakingly put presentation. It was a very a lot of things to learn in that case, and I think you have given a very good template for us to take the meeting forward. And we would, and Professor Ben would actually tell us how to look at these things in a better perspective and how to execute our decisions better. So thank you, Dr. Mona, for your efforts and the presentation. Thank you.
Yeah, thank you so much.
So, Mr. Sagar, can you share the next slide? Okay, it's a proud privilege for me to be introducing Professor Ben Wheeler. We welcome him to today's program. We are very lucky to have an opportunity to listen to him. Most of us know him. We have all learned a lot from his work. So Professor Wheeler is an academic pediatric endocrinologist working in the southern half of the South Island of New Zealand. He has a passion for diabetes technology and improving the lives of people living with diabetes, both young and old. So he has over 250 publications, book chapters, abstracts, and a lot of important commentaries. The majority of his work is related to diabetes and diabetes technology. His work is highly collaborative, and his team has multiple clinical trials in advanced diabetes technology running at any one time. And from what I personally know, he is actually really in those trials, and he's always a hands-on doctor to all these patients. He has a lot great reviews on the internet. So I would request Professor Wheeler to please enlighten us about diabetes technology and some tips on the usage of the newest pump, that is the 780G. Professor Wheeler, the stage is all yours.
Oh, thank you so much. It's a real pleasure to be here. Good evening to you all. It's evening here in New Zealand, but hopefully I don't run out of light. Real pleasure to be here. I'm hoping I'll get to meet many of you at the APES meeting in New Delhi later in 2024. It'll be a real pleasure. So please come and introduce yourselves if we get that chance. But I think that'll be a great meeting. So really looking forward to that. And thanks, Ahila, for thinking of me. I've known Ahila for some time now and really greatly respect her skills and knowledge. So it's great to have an exchange here because she's normally telling me what to do. So so that's great. Now this is an area I'm really passionate about, and so a real pleasure to be able to talk about it. I'm just going to see if I can get my screen going here. Navigating multiple screens. Now, hopefully you've got my main talk there. Is that right? Ahila, can you see?
Yeah, I can see it. That's going
Yeah,
on.
great.
Thank you.
Just let me know if it starts doing anything weird. But so I'll talk about technology, but also I've got a whole section there on practical tips for 780 use, which we are currently. I've had many hundreds of patients on the system now, so and used at research and clinically. So we've stressed it in all sorts of ways. So hopefully I can provide some insights into some practical tips for using it. Just as a wee introduction, this is my region. So I work in the southern half of the South Island. It's an area, I guess, about the same size as Austria. So still pretty small compared to India, but quite large by New Zealand standards. The top slices are there are my city, Dunedin, where New Zealand's oldest medical school is. But of course, we're in a region there with Queenstown, the Central Mountains, and right down to the bottom as well. So hopefully some of you can experience that at some point. Just have a slide here with disclosures. I guess we've been doing lots of work in this area, so it's important for you to note that I have taken funding from the main technology companies there. So I thought we would cover just the background and why I think diabetes tech is so needed. I've just got a little bit on CGM just as we navigate through into automated insulin delivery, and then I'll focus primarily on a few of the different systems available, but really then hone right into 780G, talk about evidence. I understand 780 is the main system used in India, so I think I focused most of my talk at that level. So it's just over 100 years now since the discovery of insulin. So I guess this is what it's all about, but these are these early photos. And if you haven't read The Discovery of Insulin by Michael Bliss, I highly recommend it. It's a really enlightening read about, a pretty fascinating time in history. And these are you've all seen these photos and just that miraculous recovery that occurred with these very sick children after the discovery of insulin. None of them looked very happy. And I think things were still pretty difficult. And I think people were only just starting to realize the added burden and the substantial impact that having diabetes really has. I've got this slide in here as well. This is just a really interesting slide because, again, hopefully all of us can learn from Banting and Best and McLeod and Collett. This is the only photo in existence with more than 2 of them in it. And they fell out quite rapidly and their collaboration ended. And I guess for all of us, we need to keep that in mind. Most of my great enjoyment, the real pleasure in doing research and working clinically is in the collaboration, is in the friendships in my colleagues. So just don't forget that aspect of things as you navigate, all the excitement of your careers. Here's Leonard Thompson. He's the first child and the first person ever to receive insulin. And I really like this photo because when we're thinking about children and adolescents, here's him in his early 20s, and he died shortly after this related to complications and diabetes. So this was the first time they really became aware that diabetes wasn't cured. They just, insulin was temporizing things, and there were a lot more challenges for us to resolve. And I guess here's one of our cases. This is Miss L. She was diagnosed at 3 years, now aged 18. She's on injection therapy. A1C persistently, sorry, we use SI units, but so that's just over 13%. A1C persistently at 13%. And then when she was referred to me in one of our research trials, the endocrinologist from the adult system, there was this quite poignant sentence in their letter where it says, unfortunately, I felt rather powerless talking to her. And so the question it really is where to from here, and why does it even matter? These are American and Australia and New Zealand data, but I'm sure if you looked at Indian data, and I'd love to see it if you have it, you'd find exactly the same finding. And this lovely red line here, this red line here is target. And of course, we're pushing that lower and lower. So I've set that at 7%, but many people would say that should be 6.5% now. But you can see the vast majority of people aren't coming close to meeting target using traditional insulin delivery technologies. Here's the American data, even more woeful. And in fact, deteriorating over time. But you see this in this youth age group, we get these mean A1Cs above 9%, which is really just not acceptable. And you can see here in Australia and New Zealand, when this data was published in 21, 18% of children and 10% of the youth are reaching the targets that we think help prevent complications. And why does that matter? Well, here's the Scottish data. But if you're diagnosed before the age of 20, you see here in the Scottish data that you lose 11 to 13 years of life on average. You see here men and women without diabetes, 76% and 83% of women survive to 70, where in this data only 47% of men and only 55% of women survive through to 70 years of age. If we look at people who are diagnosed earlier than 10 years, it's even worse. Here's Swedish data, between 14 and 17 years of life lost if diagnosed early. So traditional therapy, injections and insulin pumps on their own are just not cutting it, and we need something better. And I guess this is where we get work in advanced hybrid closed loop or automated insulin delivery. And I think while we wait for some cure, and all my colleagues working on immune therapies, while we wait on them to solve things, technology is going to be the gold standard that we have to help all those people with type 1 diabetes worldwide. This is our work. We span the whole country. We're all good friends, all work very collaboratively, and there'll be PIs or co-investigators based at different sites and different studies, just depending on what we're doing. But hopefully I can pass on some of the experience we've had over the next few minutes. I thought we'd start with glucose testing. Glucose testing's been with us for a long time, and it really is the key to how technology works, and it's the key to all the decisions both us and I guess the artificial intelligence uses to make decisions. So here's how we do it now. We've got continuous glucose monitoring in a variety of ways, and of course I should be replacing this slide now with the Dexcom G7, which has been available in New Zealand for some time now, and moving into the Libre 3 algorithm as well. But again, one of the other things that people often overlook, CGM provides so much more information than, say, A1C, which we used to rely on so much. So here's 3 images here, all an A1C of 7%. And then we're looking at glucose tracers. And just reminding you, this is what we want, this 100% time and range. That could be an A1C of 7% if it was just slightly, in the sort of 8 or so range. But here you've also got an A1C of 7% with quite a bit of time high, time low. And then this is really the image on the left that we really don't want, where you've got lots of time high, lots of time low, and not that much in the middle. So A1C is a very crude measure, and CGM, and in particular time and range, gives us such a more dynamic way of navigating people's diabetes. Just to remind you, we're talking about interstitial glucose. And this is really interesting because it's largely the same glucose oxidase-based reaction that we've used in self-monitoring of blood glucose with capillary glucose sticks. And now this is the key for all our direct diabetes decision making. And just to quickly remind you, this issue around lag, when glucose is stable, you've got these lovely images here from Abbott that explain it so nicely. Things are ticking along. The carriage at the front's the blood glucose, the engine at the front's the blood glucose, the carriage at the very back's your sensor glucose. And if things are just rolling along there quite gently, they're essentially the same. But just remember that when things are changing very rapidly, there may be a little bit of a lag, and we need to keep this in mind. Particularly, in my experience, over-treating hypoglycemia, low glucose values, is one of the bigger problems with people relying on their CGM always, and they need to take this into account. In my experience now, managing hypoglycemia appropriately, not being fearful of it, is probably the key challenge to help people have more time in range. So here, I've basically summarized all, but here's the ADA guideline for adults with new onset type 1. This is the same for the EASD guidelines now, and also for the ISPAE guidelines that I've been involved in writing. And basically, the CGM is the gold standard now for glucose monitoring. And if it's available, it should be the first choice. And I acknowledge that for many people in my country and worldwide, that is still not yet realized. But we all need to be aware that is the gold standard for how we should be managing diabetes. Just to give you a more extreme example, this is Swedish data from 2020, where you can see almost 100% of all children in Sweden up to age 17 are using CGM. And that's really what happens once you make this freely available to all people with diabetes. So the future's here, and I guess over time, hopefully we can all have a graph like this. I've just summarized the main systems available here. And we can talk more if some of these aren't available in India, but Dexcom ONE is essentially a competitor for the Freestyle Libre 1.0, 2.0. It's a cheaper paired back version of the G6 and the G7. G6 is here, but slowly we're phasing into primarily G7 use, and G7 will be used with all our Control-IQ and Tandem pumps starting in January. It started in the US already. New Zealand's the second country to access that, so we'll see a transition through there. And G7 is a beautiful sensor. We've got Guardian 4 here, and we're starting to use the next generation Guardian 5 system, I guess, which is transmitter free in a number of our research studies, and got extremely positive feedback with that. So that's something for you to look forward to, along with extended wear infusion sets. So there's a lot of work going on here to improve the burden and improve the stability and improve the experience of automation for people with diabetes. And then there's the Libre systems. Libre 1 largely phasing out. We use primarily Libre 2, and we use that primarily with real time with the new app updates. I'm not sure if that's available in India, and it's essentially the Libre 3 algorithm in the Libre 2 casing. We can't yet buy the smaller form factor in the Libre 3. So how effective is CGM? I just thought I'd put some work up from Mona from last year, and one of our PhD students, but just sort of highlighting, I'll just put a red box here. Time and range, CGM is superior to capillary glucose monitoring when it's in a standalone fashion. You can see there's a variety of studies here over quite a span of time, but on average about a 5% improvement in time and range. Substantial improvement in time below as well. But again, this is just about to be published from Yongwen, who's a postdoc working with us from China. And she's done this nice study just looking at the 5 available studies that compare intermittently scanned CGM with real time. And again, just highlighting 7% improvement over intermittently scanned with real time. So when it's available, real time is the form of CGM we should be using. And I guess intermittently scanned CGM slowly becoming extinct anyway as Libra moves into real time over the next year or so. Early initiation of CGM really does matter. I put all of our patients on CGM at diagnosis, and within a day or so of diagnosis. But here's this interesting data out of the UK where they tracked people's A1C over a long-term track, and they just found that in those first 5 years are where you had the most ability to make changes. I actually think this is a bit old-fashioned now, because we're making massive changes in A1C using automation in people who've had difficult to control diabetes for many, many years. So I think this is really old data, but I think it just highlights that setting a healthy long-term trajectory with your life with diabetes early is really important. And here's this other really nice data, just highlighting that if you had to pick one thing, pumps or CGM, you'd put people on CGM. So using injections with CGM over 1 year, starting at diagnosis in Colorado, ended up with an A1C of 7.7%. And that's a 1.5% difference than the people who only use multiple daily injections. You can see there pump only gets you about 1% away from CGM alone. If you had to pick one technology right now, I would place people on CGM. I wouldn't put them on a pump. If you can't have both, go for CGM. I would acknowledge that data from America probably means quite considerable inequity in income, and it may be that we're seeing some other socio-demographic issues influencing this data as well. And so we all need to be mindful of that. So just some key points here, just in this very first part of the talk. CGM is the gold standard method of glucose monitoring. All current consensus statements recommend that CGM should be the standard of care and offered to all people with diabetes. And I acknowledge that due to equity issues in my country and equity issues worldwide, that's not necessarily the case. Real-time CGM superior to intermittently scanned in most circumstances. And it really, if possible, we would start CGM as soon as possible after diagnosis with this aim to establish a long-term healthy relationship with diabetes. And really now we'll move into automation. This is a pretty well-known example of automation technology, but why I like this slide is it really highlights all the things that an insulin pump and an automated insulin delivery system needs to do. You need an engine, so the pump. You need sensors to look around, so that's in the case of diabetes, the CGM, and you need a clever algorithm to make all the decisions required with that information to keep things moving on track. And in terms of Medtronic 780G, this is what you have. You have a patient, you have a pump, you have a sensor, and you have a meter if you need calibration. We only have Guardian 4, but certainly our original research in 780 in the original pivotal trial used Guardian 3. But Guardian 4 has been a nice incremental improvement over Guardian 3. We've got a paper from one of my PhD student, Shaker, just describing how we transitioned in one of our studies from Guardian 3 to Guardian 4, and that was a positive experience. And of course, here's Generation 5 sensor. This is just taken off the internet. That's the form factor, and it's a beautiful sensor, and we're enjoying using that currently. So in New Zealand, I primarily use Control IQ with Tandem, as well as the Medtronic 780G. And I have more patients on 780G than Control IQ, but they're both good systems. We have a handful of people using DIY, but given that pumps are fully funded and the IPSO pump to run DIY isn't, it's not something I push very hard. Of course, you've got Omnipod, patch pump, which some people were very interested in, and this capacity to bolus from the phone. Same with the CAM APS system using either the Dana or the IPSO pump, primarily more IPSO at the moment. I think this is a really interesting system as well, and has the youngest age usage approval at the moment. So I think also an interesting system, one I haven't had much experience with, I need to state. So here's the original study that we were involved in with 780, and there had been a wee journey coming to that. But this was in 2018 into 2019. This is the data that was used for European regulatory approval and subsequent approval throughout the world. Other than the US, they need their own studies for FDA approval, and done with my great friend Martin, and we had 30 patients in Christchurch and 30 patients in Dunedin, and there's the study there. But here's the data, and you get 3 hours improvement in time and range. 3 hours healthy time and range for each person going from automation from sensor augmented pump therapy. So the control group in this study was 640 with predictive low glucose management, and then into 780. But these were healthy people. These were people with an average A1C of around 8% or so at the start of the study. So the healthier the people that come into your studies, the less improvement you see. But what we did see is that youth improved by 3.5 hours per day. And you see pretty much in every automation study using first adopting healthy volunteers around about a 12.5% or so improvement in time and range with these technologies, and of course without any deterioration in hypoglycemia, and usually an improvement. And you can see here these sort of classic images that we produce every time, where you get really beautiful control overnight and then still improvements during the day. But I guess just normal life with diabetes makes daytime control a little more challenging. Just to show an alternate system, and just to prove that point, that you get this sort of 11 to 14% improvement with whatever system you use. This is some work from another one of Martin's and my PhD students, Mercedes. This is using DIY automation, using Dana pump with open APS system, but again, about a 14% improvement in time and range versus sensor augmented pump therapy. And again, 60% of participants meet a time and range target of over 70% by the end of a study like this, versus 15% using sensor augmented pump therapy. So these are quite important improvements in health for people, especially when we look back at that mortality data I showed you at the beginning. Here's data. Of course, if you take people who are less healthy, they tend to improve much more using 780G. So again, if it was up to me, I would be prioritizing those individuals first, rather than those who we tend to prioritize, and I'm guilty of that as well, those who are already in target or already quite healthy before we put them on. But if you take those who are very unhealthy, so here's a study with a mean HbA1c of 10.5% at onset, and they come down to 7.6% after 3 months. And that's sustained out to 12 months in that data. But you can see everybody in the study improves, but you need to use it to get that improvement. And you can get some quite dramatic improvements for some people. It can be really life-changing. Here's that data in terms of time and range. And you can see if you take people with a very low time and range to begin with, and just keeping in mind the Medtronic blinded CGM system kicks out quite a large proportion of the data above a glucose of 400. And so the time and range here is artificially high at baseline. When it says it's 27.7%, in reality, it's probably between 5 and 10%. But anyway, you get at least close to 40% time and range improvement, even with that caveat. And what that means is you get another 9.3 hours per day with healthy glucose. So I think I'm hoping that I'm making that message very clear, that there is no way to get diabetes data in large numbers of people without using automation. There certainly are wonderful, highly motivated individuals who can do the same. But if you're wanting to really reach large numbers of people and really bring all of their data up to a healthy level, then automation is the only way currently available. Here's the real world data. And again, well-motivated early adopters, probably with quite healthy, there you go, there's estimated A1Cs in this data in Europe of the first 4,000 users of 7.2%. Post-initiation, the estimated A1C is 6.8%, but you can see mean time in range jumps from 63 up to 75. And importantly, time hypoglycemia falls. And that's what we generally see in all the data at this point. We've got a nice RCT that's just completed randomizing onto 780G people with very out of target A1Cs and from quite diverse populations, so about 40% non-European, low socioeconomic. But I'm not going to show you the actual data. It's pretty much exactly what I've shown you in all the other slides. But here's the safety data. You were talking about DKA earlier. Just saying, even in those who are very unhealthy, so A1Cs, at my experience extends up to people with A1Cs of 17%. I think one of our trial participants must have the world record for the most unhealthy diabetes in any randomized controlled trial. It's safe, even in very high risk populations. And you can see that DKA data from an RCT of 80 people, but we've now put hundreds on in studies. No DKA in the AHCL group and the automated group, and those in the control arm, 2 episodes of DKA, episodes of hyperglycemia with ketosis. And while in this study, 85% are injection users at onset, some of them are on pumps, an infusion site infection and one there. But basically, if you've got unhealthy diabetes, you have considerable risk of both severe hyperglycemia due to erratic glycemic control, and you also have considerable risk of DKA. And the risk of running an infusion set in those people tends to not be increased, although you need to take a case-by-case approach to that. And if they're having considerably bad experience with infusion sets at a rate higher than they were before the pump, then you could consider taking it away. But in my experience, with the right anticipatory guidance and education, automation's safe and almost everybody that you want to use it on. So key points here: automated insulin delivery without doubt is the gold standard for type 1 diabetes. It has the potential for very large improvements in glucose for some people, and it's generally safe. It reduces burden and it improves people's quality of life. Not everybody will use it. When we take those high-risk people, about 1 in 10 tend to struggle quite a bit. And I think that really reflects that their general lives contain considerable struggle. But anyway, taking people considerably out of target and able to help 90% of them, that's a very positive thing. And I guess this final point, and this is important for all of us, including myself, don't prejudge who may or may not do well. In my experience, doctors aren't actually very good at deciding who will do well with many treatments, and having an open mind and giving people a chance. And I guess if we're going to be patient-centered in our therapy, then we would focus our energies on what the person in front of us wants and how we can help them achieve it, rather than using our own prejudgments on who may or may not do well. And just remember that the biggest gains, and maybe those who have the most to gain, are those who are less healthy. So I'll just bring you back to Miss L. So she's 18, had the stubborn HbA1c of over 13%, considerable financial hardship. So here's her A1C after 3 months of using 780G, A1C of 6.5%, loving the system. She's now been on it for a couple of years. This is older data now. But see here, A1C, time in range now of 75%, no hypoglycemia, sense-aware time over 90%, and using the system well. I'll come to it again a bit more later, but you see these beautiful nights, in target time and range, but you might notice in the bottom corner active insulin time of 2 hours, and Mohana nicely identified that. But there's very good data that active insulin time should be 2 hours to get the best out of the system for most people. Sometimes you do need to reduce it, but keep that in mind. The old paradigm of 3 or 3.5 or 4 hours is not appropriate for 780G. Just again, highlighting her glucose data, these beautiful nights. And you can see when you bolus regularly. So here's a day with 5 meal boluses, getting 87% time in range. Here's a day with only 2 meal boluses and ending up with 62%. So there's a key message there as well. Here's, I think we've got a lot to learn from Mr. L. A1C of 17.6% for over 5 years. So the only way to measure this is in a laboratory. You can't use point of care testing because the DCA analyzer flattens out everybody at 14%. Frequent hospitalizations, and he's clearly at extremely high risk for complications and early death. Here's his data after 3 months of automation. And you can see here the fascinating thing about him is he never carb boluses. So he runs in full automation, but he still gets these 70, 60, 50% time and range days from a baseline of 0%. Trouble-free. After 6 months, so he's now been on a couple of years, A1C in the 50s. 50, so 7.2%, down from 17.6%. Weight gain, muscle gain. In my experience, men who've had very high A1Cs before you automate them, particularly men, have quite nice changes in their body proportions. And you get good muscle gain and good fat gain in appropriate places, so generally positive. So automation, there's no doubt that it saved this guy's life. And these are the sort of comments you get from people in studies, particularly when they've had access to things that they've never had before, but just really highlighting how much for people with diabetes, technology offers a lot of hope for them at the moment. As close to a diabetes holiday as I've ever experienced. This is a mum. My favorite moment from the trial was when she casually remarked to me, I forgot I had diabetes today. And then quite a sad one at the end there, just highlighting the fear that parents and people with diabetes have about coming to harm at night. And again, automation provides considerable peace of mind around that issue of hypoglycemia at night. I think in that American data, personally, I think the fear of hypoglycemia is the reason why the type 1 exchange data and why the American mean A1Cs are higher than everybody else's. So practical considerations. Hila, am I okay for time? Hopefully I can just go through some.
Yeah. You have enough time. Yeah, it's good.
Oh, neat. So I'll go through how I do it.
Thank you.
And Mahana really nicely went over this before, so I won't spend long on this. But just remembering in 780G, first thing, you can set your target, 100, 110, 120. Remember, in the real world data sets, the healthiest diabetes is achieved on 780 with a glucose target of 100 and with an active insulin time of 2 hours. So generally, we should start people on those settings, keeping in mind if they're smaller children, you might start in the middle of that. I often start people at 2.5 hours and I start them with a target of 6.1 and then quite rapidly try and push them to 100 from 110 and push them to 2 hours of active insulin time. If I'm starting an adult, I would generally start them on 2 hours. Basal insulin's adjusted every 5 minutes based on sensor glucose. So that's B. You can see that along the bottom here. And this just highlights how variable every single day with diabetes can be. There's so many things that influence glucose. And just keep this in mind. If you're ever using people on pumps without automation, this just proves to you, there used to be colleagues of mine who would do basal rate testing. You know, they would admit people to hospital or get them to have protein-only meals and test their basal rates. There's no logic to that. Every single day with diabetes is so different that you can't really accurately do that. And if you look at automation traces every day, you'll see there's not a single day where the basal rate looks the same. Then we see the autocorrection target here set at 6.7 or 120, but on the graph, actually, it's set at 100, and that's where it should be for most people. Although I acknowledge for many children, particularly if they're a little erratic in their lifestyle, and same with some adults, you'll need a target a bit higher. Maybe 80% of people will get to 110 or 100. There'll be a handful that'll need the 120. And then you have these auto corrections every 5 minutes if the max basal's reached. So once your basal's maxed out, then you go into auto corrections, and these only correct to 6.7 as determined by the algorithm. And just remember the temp target for exercise, or if you're having difficulty with hypoglycemia, you'll get no automatic corrections while in temp target mode. And this is what I'll refer to as the ABCs for 780G. Every system is different. So the Control-IQ tandem system is different again. All of the systems are different, but for 780G, and Mahana nicely noted this, really you've got active insulin time. That's your primary way of influencing glycemic control. You've got your basal target, so that's the B, basal target. You can set that, and again, try and get people to 100 if you can, but keep in mind the burden of hypoglycemia. And then you've got the carbohydrate ratio, and that influences, again, how powerful the auto corrections are, but also corrections with food. And those are the three things that you can adjust. You cannot have any influence on glycemic control by adjusting the basal rate when you're in automation, and hopefully you're aiming to achieve most of your time in automation. There's nowhere safer for a person with type 1 diabetes to be than automated. You can't influence the correction factor. There's no point changing the insulin sensitivity factor, or if you call it the correction factor, there's no value in that. So basal rates and correction factors, you need to adjust them periodically so that they're not completely out of date with growth. But otherwise, they don't influence control in any way other than the handful of percent fortnight when they're in manual mode. So that's just a really, really important point, and many people forget that. So just again, active insulin time. This is really, it's not actually in the 780 how active insulin is. It's your lever to tune how aggressive the algorithm is. And really, ideally, it wouldn't even have time. It would just be a symbol of aggression of the system. But 2 hours gives you earlier, stronger auto corrections. And the longer you go beyond 2 hours, you get later, weaker auto corrections. So again, that wonderful case with the steroids, the key is to, well, before you go on the steroids, active insulin time should be as short as you possibly can get it. But as soon as things aren't going well, you need to get it stronger. And just remember, the system takes 72 hours to generate maximum delivery. So this Umax, or the max delivery, that's calculated, but that determines how aggressive the overall algorithm can be. And so people who have very erratic diabetes, or like in that wonderful case where you've gone from, say, a total daily dose of 40 units one day, and then you put them on steroids, and then they're on 80 units the next day, the system can't deal with that. It takes 3 days to catch up. So just remember that. Here's your basal target. Remember, the default or recommended target is 100, but you need to use your judgment for younger or people with more erratic diabetes, people who exercise erratically. They have an exercise day one day and an office day another day. People who work in extremely physical jobs, also with erratic control. Keep that in mind. And then the temp target. Please don't forget this. It's so important. It sets the target at 150, and you can set that for up to 24 hours, but you will not get auto bolus while temp target's on. So it's much safer for hypoglycemia, and use it for exercise or at any other time where less insulin is desired for any reason. Sometimes in very young children, you need to use it to stop the algorithm driving them low. And I've definitely used that before. It may need to be started 1 to 2 hours before intense exercise. So just keep that in mind. Ideally, people who are very physically active, they're journaling their data so they can really maximize the science behind keeping themselves in target. So here's the carb ratio, a much lesser impact. But again, I'm going to skip over most of this. But and I noted this in the case with Mahana, generally in practice, to get the best out of 780G, you should use a calculation of really a minimum of 400 divided by the total daily dose. So Mahana, in your case, I calculated that out, that the ideal carb ratio for that individual would have been about 6. If you use the rule of 300, I find many people end up on the rule of 300. That would have given your patient a carb ratio of about 5. So carb ratios while using 780G tend to be much stronger than what we're used to using when people were on multiple daily injections. And over hundreds of patients now, that's very clear to me. Sometimes I try not to drive people's carb ratios under a ratio of about 4. But sometimes it even needs that. But carb ratios in the 5 to 8 range are very common, even in children. So just quietly strengthen them. Be mindful of how strong they're getting. Warn them that if they go into manual mode for any reason, their carb ratios are artificially strong. And they will need to take that into account. And you need to be mindful of what's happening with hypoglycemia post meals. But the SmartGuard safety prediction will adjust the dose automatically if it feels things are going to be too strong. But again, I can't say that enough. Much stronger carb ratios in practice than you would initially assume that you would need. So looking at how to review reports. So here's a report. This is the ambulatory glucose profile. This is the first piece you should look at. And I always look at the patterns. So looking along that top bar. I look next at time hypo. How much time do I have? And I really want to make sure that that's less than 4% time under 70 milligrams per deciliter. And then I'm looking at time and range. Are they at 70%? And if they're not, how can I help get them there without increasing their time hypo? Then next, I look at adherence. So this is where you look at sensor behavior. How much time they have sensor wear per week? And how much time are they in SmartGuard? So in this person, we want over 90% sensor time. And when their sensor is in, they're running 100% SmartGuard. So that's pretty awesome. They're really working hard and they're keeping the gear running. If they've got sensor wear time under 90%, then you should start working on that first, particularly under 80%. You'll find that people's A1Cs and their time and range will substantially fall if you can't maintain sensors at above 90%. Then you look at the total daily dose. That can help you look and decide about your carb ratios and other things and how strong you can make them. Look at the set change frequency. Again, that should be 3 days. So people who stretch them out beyond 3 days, unless they're wearing a new extended wear 1 week infusion set, if you're on a traditional infusion set, in my experience, you lose about 10% time and range every single day that you stretch out beyond 3 to 4 days. So really just keep that in mind. And again, and look in this download, are they doing meals? Are they entering carbs? And sadly, they're not. So that could be something that we could look at. So we come into this page, look at their active insulin time. I've used 2 pages on the CareLink download here and stuck them together. But you can see at the top, active insulin time of 2 hours, 30 minutes. So immediately in my mind, I think, okay, they're not hypo. Time and range is about 58%. First thing I'm going to do is strengthen the active insulin time to 2 hours. Their blood glucose target is 6.7 or 120 milligrams per deciliter. That's something else we can work at. And again, just showing you how I manage alerts in the bottom left-hand corner there. Be very mindful about the burden that alarms will have on people, particularly if they're using a Guardian 3 sensor. So in my experience, if there's any doubt, set a very conservative high alarm, 15, 18, 20. And in many people, I turn it off completely at the start. In terms of low alerts, I relatively rarely use the alert before low alerts. I find them unnecessary for most people, and they just add additional burden and they increase your risk of overtreatment of hypoglycemia. But for some people, they're extremely useful. So again, there's no one size fits all, but for the average person, alert before low shouldn't be necessary. And I run people as low as I possibly can. The lowest low limit you can have is 3.2. If someone sits all night between 3.5 and 4, that's just perfect from my point of view. I have no problem with them running in there when they're in automation. If they were using it in multiple daily injections or a pump on its own, that's just crazy. You wouldn't run people that tight. But if they're in automation and they're not alarming and they're not going low, there's nothing wrong with skimming in the complete normal range of glucose. So a low limit of 3.2, that's going to have suspended for a few hours before you'll even come close to 3.2 in most cases. And when it does alarm, they know they need to take action. If they're getting a lot of alarms, you get alarm fatigue and people start to ignore their alarms. And I find that to be less safe at a pragmatic level than just having a pragmatic alarm like this. For some people, we'll negotiate that. It might be 3.4, 3.5, 3.6. I try and avoid any alarms in the 4s. Here's the same individual and looking at their trace. And you can see a few things here. They're jumping up after meals. They're not bolusing for meals. And we saw before there were a few things we could do. So immediately what I would do is I would put their active insulin time to 2 hours. I'd also immediately drop their target to 110 or 6.1 millimoles per litre. I would strongly recommend to them to pre-bolus before meals, but I would also acknowledge the burden of living with diabetes day in, day out. I'm not going to judge them if they're not doing that, but I would be encouraging them to try and warn the system that carbohydrate's coming, even just by giving a small fixed carbohydrate load. Even just putting 20 grams in would make an enormous difference. At the next review, I would consider dropping the target further, and I'd consider strengthening the carb ratio, but I'd start by doing those two simple things and see what we get from that. So some personal tips. Never make assumptions on who may want or benefit from technology, and never make assumptions on who can or cannot afford. I've seen all of my assumptions on both of those things wrong in many occasions. Sometimes the people I think will do the best do the worst. So just be aware that we're human too, and that if we want to center our care around people with diabetes, then we will take their views and their wishes into account over our own. Automation can't beat highly motivated individuals with diabetes or parents looking after children with diabetes. The way I deal with this is get them on CGM and get them on automation early. And that avoids them developing a whole range of burden-related and fear-related adaptions to diabetes that often make the journey with diabetes more complicated, and they make the transition onto automation sometimes a little harder. People who are micromanaging their diabetes before automation, say those running an A1C in the low 6%, those sort of individuals can sometimes find that automation fights them a little bit. Over time, that generally improves, and most are eventually happy with the burden reduction. But if you've got people running those sort of A1Cs safely, the other argument might be, why should they go into automation unless their burden is high? And most people who have very healthy A1Cs have quite considerable burden and quite considerable worry. So there may be some benefits to automation for them beyond glycemic control. So additional tips. People on automation need less aggressive treatment of hypoglycemia. So generally about half the carbohydrate, rapid-acting carbohydrate that you would have used for multiple daily injections. So just remember that instead of, general rules of around 10 grams to treat hypoglycemia, they'll often need around 6 grams or so. So just keep that in mind. If you're treating them with your traditional larger doses for hypoglycemia, then you'll generally get rebound hyperglycemia. Often by the time you've noted that they have hypoglycemia, they'll have been suspended for 1 or 2 hours before that happens anyway. Outpatient training is my recommended method of pump training. We do rapid onboarding. We train them on day 1. We often do a virtual train or a brief in-person train on day 2. And then on day 3, we turn automation on straight away. There's no benefit in prolonged periods without automation. and there's no benefits in prolonged education unless you've got some physical constraint that makes that difficult. In private practice, for instance, I have a company representative who would train someone in the community, and I would be on a virtual link for a very short amount of time, and we'd do all their changes in the community virtually. So definitely outpatient training. I see no particular benefit, except in maybe very extreme circumstances, why inpatient training would be required. Get into auto mode as fast as possible. There's no advantage that I can see in delaying. At the moment, with the 780G algorithm, you need to wait 48 hours from midnight to midnight. We'll see improvements in that over time. Of course, in Control IQ, for instance, from Tandem, you go into automation immediately. So less aggressive, often suspended. Sorry, my animations aren't working very well there. Aim to avoid rebound hyperglycemia. I always show people what a normal CGM trace should look like. It's nice for them to know what they're aiming for, what someone without diabetes would have. And the other thing is people with diabetes deserve to have this great CGM day. I heard this from one of the, the gurus of diabetes at a meeting once, and I really agree with them. Find a good day in every 14-day download, even in people who are struggling, and find a day where they've achieved better than other days, and keep encouraging. Don't underestimate the power of that positive feedback and helping drive them, particularly people who've been unhealthy for some time. They're often very disappointed. We often see that as them disengaging or not being compliant, but really what it is, it shows the burden that they're experiencing. And in my experience with many people with very unhealthy diabetes, some of them are experiencing enormous burden and are feeling very disheartened. And so finding ways to give them positive feedback, not negative feedback, would be my strong advice. So yeah, don't underestimate our power at influencing them, and our power, both harmful or positive, depending on how we treat these people. Bolus before eating, that's really important. And then individualize alarms to maximize effectiveness and safety. It's really important. People often are concerned about safety, put very aggressive alerts in, and these often give very significant alarm fatigue and burden. And then you get a boy who cried wolf phenomenon, where the person with diabetes begins to ignore the alarms, and then they miss when they really should be taking action. So I set all my hypo alarms between 58 and 65 generally, and I turn off, for most people, particularly at the beginning, you can always layer them in if there's a reason why they may be helpful. I turn off the rise and fall alerts. And for many, I turn off the high alarm initially and then maybe bring it in to help. Continually review these and change over time, individualize them to help the person that's in front of you. Maximize the use of the temp target exercise setting. It's extremely helpful. It'll give you small gains and it'll minimize time hypo. And remember to suspend the pump if they disconnect. Otherwise, you run the risk of hypoglycemia when they connect back up following exercise. And don't sweat the small stuff. Plus or minus 20 grams of carb on 780 is generally not an issue at all. And in fact, I showed you that trace before of someone achieving high 50% time and range, never carb counting or putting a single food in at all. So the key is routine and having a relatively even lifestyle with 780. 780 does not like people who have a total daily dose of 40 units one day and 60 units the next day. Reduce snacking as you're able, particularly in the hours before bed. So we generally encourage people to close the kitchen after dinner, and they shouldn't be eating carbohydrate in the 2 to 3 hours before they go to bed. And this is a small print thing. I haven't seen this too much, but occasionally if someone has a very unhealthy or high carb diet and they don't modify the way they eat, 780 will just drive all of that into weight gain. So just be aware if they're extremely unhealthy and have been managing that by peeing a large amount of it out, 780 will lead to some weight gain. In my experience with men, it tends to be generally beneficial. They gain muscle. Some women don't appreciate the weight gains that they may get. But again, I'm generalizing. It very much dependent on the person. And in most people, it's not a major issue, but something to be mindful of. Few final things: maximize the effectiveness and safety, engage and develop your multidisciplinary team, wrap around your dietitians, your diabetes nurses, your clinical pharmacists, whoever you've got to help you look after them. Make sure you've got regular follow-up as much as you're able to do. It needs to be repetitive education, lots of anticipatory guidance. Make sure they've got annual action plans for disconnections, ketones, DKA. Just got an example of our action plans there on the side there, a plan of how to manage ketones, what to do, troubleshooting, all the phone numbers they need, and what their settings should be if they were to lose their pump. You know, it always happens on a Friday just before you go on holiday. They need to know how to go back to their long-acting insulin and their previous settings. I think it's really important that you get their apps working. They'll need help from the company to do that or from you, but make sure they can see their own data and ideally motivate them to give you the data when they come to see you. It's always a bit annoying when you're fiddling around trying to get their data out of the system, especially if you've got very little time. And I would encourage you, and I'd encourage my patients to learn how to do their own self-review. They should be looking at their own data. They should become experts, and they should self-assess the impact of different foods, physical activity, their temp targets, their hypos. And I have no problem with them once we've trained them up and making them independent so they can make some of their own decisions and changes as well. Just remember the downside. Cutaneous adverse events are quite common, and I just draw your attention to the Panther program. It's really good. It's got wonderful material there on skin solutions for how to use, spray on steroid like Flixinase, how to use barriers, etc. And it can be quite nasty, and some people mostly don't need to cease use, but you do need to manage this appropriately and get on top of it quickly. So here's the Panther data. I really like this website. If you guys haven't used it, I'd strongly recommend it. The skin solutions in particular are very helpful. And there's also some nice point of care data tools there to help you read the downloads. I went through it quite fast, and they'll help you train yourself up, whatever system you're using, whether it's Omnipod, whether it's Control-IQ, or whether it's 780, so that you know how to manipulate the system to get the best out of it. So just concluding, automation is diabetes and life-changing for many. It is the gold standard for current management. And some of the things I've learned dealing with people over many years now with automation is it's often a way for people with diabetes to develop a more positive relationship with diabetes. And I've been, that's a very positive thing, something that's warmed me over time is seeing that. It's also a chance sometimes for improved engagement and to renew engagement with us as the diabetes team and or parents, because it takes pressure off all the people who've been caring for them over time. There is absolutely a decreasing role for finger prick glucose. CGM's the gold standard, and I believe all people worldwide should have access to that. And worldwide equity is our biggest issue now. And I guess all of us should use the positions that we're in to lobby for technology access as much as we can. And quite clearly, the price needs to fall. So hopefully I haven't gone on for too long, but happy to talk and take questions as needed.
Thank you so
Thank
much.
you. Thank you, Professor Wheeler. Thank you so much. And as you said, automation has a potential to be life-changing. I think most of the audience today would agree that this talk has the potential to be practice-changing for many of us. Thank you for a lot of practical insights. and evidence-based tips. And I am sure that everybody has gained a lot from it. The session is open for questions. Please put them in the chat box, and even if you want to ask, you can ask them.
I may have said one or two things that's challenging for some people. Please feel free to pop a chat in and talk it over. But yeah.
So as we await questions, I'll just put in one of my own. Professor, how do you approach the percentage autocorrection on the care link?
Yes. Well, it's a little bit out of our control. I guess it sometimes gives you an idea of how much they're interacting with the system. And my participants in some of our trials who've come into the study with quite elevated HbA1cs, as a general rule, I find if you've got an A1C of over 10%, for some time and you go into automation, about 75% of all their insulin delivery will be automated on average for those people. It'll vary. Some of them will be almost 100%. And for some, they'll use the system in a more traditional fashion, and it'll balance out more like at 40 or 50% of their bolus insulin. But there's no right or wrong as long as they're in target. Okay. So if someone's achieving target using some quirky or unusual method, as long as it doesn't cause them too much burden and it's not causing them too much hypoglycemia, I don't care how they're doing it. There's no right or wrong way to stay in target as long as you're safe and you're not experiencing a lot of burden.
Thank you. So please put in your questions, and Sagar, is there any way we can get the questions in addition to the chat box?
And that's why time and range is so important compared to A1C, because time and range gives you a much safer reflection of how healthy they are. Like that slide I showed you with 3 people with an A1C of 7%, 2 of them are actually quite unhealthy. So again, more and more relying on CGM to give us time and range.
Okay. So we had another question after the case by Dr. Kavita Bhatt. So how would you approach that situation like we had in Dr. Mohana's case, as in the risk of DKA in the interval that it takes for the pump to adjust? So if you are encountering that situation, how would you approach? What would be your advice for everyone to approach that situation?
It's a really good question. It's a really great case because it really demonstrated lots of challenges, and clearly automation in its current form isn't there yet. It's exciting to me to see what's coming through, into better systems, and we're already using some of those. So the future's bright. I guess what I would do is I would maximize what you can. I would have that AIT at 2 hours before entering into the steroid phase. Right at the beginning for that person, I felt that their carb ratio was probably too weak for automation. So 780G with a total daily dose of about 40 units per day, maybe before they went into steroid use, I would have thought they'd have a carb ratio minimum around 10, maybe even stronger. And during that phase where they were on those very big total daily doses, clearly they would need a carb ratio. I would be incrementally strengthening that to get it. And I wouldn't be scared of numbers like 5 or 6 as a carb ratio on an individual like that. The Umax is going to take 3 days to really start at changing the algorithm safety parameters. So you have got this sharp 3-day period where things won't be ideal when someone changes so quickly, like on steroid therapy. So it's a physiological challenge that the pump isn't designed to deal with. I think the chance of them getting DKA is very low, because you're still delivering 50 units a day or something like that. I think the overall risk of DKA is low. you can manually autocorrect on, you can do a correction by entering a glucose and doing a manual correction even while in 780G automation. So that's how I would manage that. I would be carefully looking for ketones though, and not thinking that the high glucose levels are all due to the steroid. Infusion set failures happen at least 10% of people per year. Everyone with diabetes using a pump will experience an infusion set failure. So don't be lulled into thinking their high glucose is all steroid.
Thank you, Professor. So,
Thanks so much, Ben.
thank you, Professor Ben. Thank you very much. Thank you.
It's a pleasure. Hopefully that was helpful.
Yes, definitely it will be. So with this, we come to an end to this session. And for the next session, I would like to invite Mr. Harsh Kohli. And Mr. Harsh is a very prominent and a well-known person in the patient support sphere of diabetes in India. He's living with type 1 since 31 years and he's a father to an 11-year-old. And he's doing well. His son is also doing well. He's a North Lead for Type 1 Diabetes Foundation of India. He's co-founder of Diabetes India Youth in Action, the DIA Foundation. Certified Diabetes Educator and Certified Pediatric Diabetes Educator, Associate Fellow of ISPAE. He's been actively working for the cause of patient education and empowerment since 2017. And today he will be telling us the Indian scenario and his insights and experience on CGM use. Over to you, Mr. Harsh.
Thank you, Dr. Saurabh, for the kind words. And at the very onset, I'd like to thank ISPAE, Dr. Ahila, and everyone for giving me this wonderful opportunity to speak from the perspective of somebody living with type 1 diabetes. So I'll speak more and maybe so I'll be speaking on the practical hacks when it comes to continuous glucose monitoring. So, and what we are briefly going to cover is what all these things are, what SOCIN is, how to activate the sensors, particularly the Libre Pro, because in India we have the Libre Pro. How do we get readings on a smartphone in Libre Pro through GLIMP? Further, how do we calibrate Libre Pro? Then the most important question, how do we convert Libre and Libre Pro into real-time CGMS in India where we don't have any real-time CGMS per se? So difference between blood glucose readings and sensor readings, how do we accommodate that gap? And most importantly, is it really possible to extend the sensor life? So coming back to the first point, what SOCIN is. So what we do over here is, and I've been extensively talking to people within the community across the country. So what I've advised them over these years and what we gradually build up as a practice is that I put on the sensor today and activate it tomorrow. So this enables the sensor to be properly placed inside my body to allow the local site of the sensor application to recover from the initial shock. And this gives better readings. So even on day one, we get readings when compared with the glucometer, the readings are much closer to the glucometer readings. In practice, I've even come across people who now put in sensors 2 days before, but that is very impractical for all of us to do on a regular basis. So even if you don't have time for 24 hours, I have practically examined 6 hours before you activate the sensor, just apply it and it works. Now in India, unfortunately, everything is out of pocket. We do not get any reimbursement of any sort from the government or our insurance companies. So even if we have to buy a needle, it's from our pocket. So it becomes very imperative to see what is beneficial on the cost front as well. And secondly, most of people in India, they find it difficult even to cover the cost of daily SMBG. So here we're talking of moving them onto a Libre on a sensor. So Libre Pro comes into picture which was initially meant for doctor use only, but now it's the most widely used sensor in India, primarily because it's cheap. But then, because it's cheap and off late in India, Libre 1 has been launched. So from Abbott, we are facing difficulties in getting access to the readers, and reader is very much needed to activate the Libre Pro sensor. Everything has a silver lining. Fortunately, there are a few apps. I would like to name Ultra Human, although I just again reiterate that I am in no way associated with with the app in any way. We do use the app to activate the sensor on a smartphone. It's very simple, very easy. You download the app. You do not need to go in for any paid subscription of any type. Just download the app, and at the bottom end, it shows an option to activate a biosensor. You pair the biosensor, and there you go. And on your smartphone, uh, the app can be activated even through an iPhone, but to get the readings via Glimp app it can be done only on an Android phone, and the Android phone has to be NFC enabled. In our practical experience, OnePlus models have been found to break the NFC antenna of the sensor. So we kind of discourage using OnePlus phone models. Samsung, Motorola, we have not faced any issues using those phones. Glimp is available on the App Store. You can just download Glimp app, and the sensor is usually on the NFC is usually on the backside of the smartphone. You scan your sensor with the Glimp app, and you get the reading. But then there is another thing, that although Libre and Libre Pro both are factory calibrated, on the Glimp app, it allows us to put in manual glucose readings. On the app interface, you can find this. It's very easy on the settings button. You just click on that button and you can enter your blood glucose readings. But there is a catch over here. We enter our blood glucose readings after a time gap of 15 minutes. That's done to accommodate the lag which occurs between the interstitial fluid and the actual blood sugar values. So like if you're checking your blood sugar at 12 noon, you input that value at 12:15 in your Glimp app. So gradually you will see that the algorithm catches up and your readings will become more or less coherent with the glucometer reading. And also remember to input the calibration when your blood sugar readings are more or less stable and you are in between 70 and 180. Beyond that, we have observed that the algorithm goes into a tizzy and it kinds of ends up in a confused state, and it starts showing very false values. Now, since these are intermittently scanned devices, how do we convert them into real-time CGMS? There are devices like Mayo, Bubble, and Bluecon available we can order them online from outside of the country. And Mayo is the most widely used product. Why? Because it's easy to source, it's easy to set up, and most importantly, the difference in the readings is very less. It's a very small device which latches on to your blood glucose sensor, and it can connect to all phones. You do not need an NFC phone to use it. You can use it with your iPhone. You can use it with your Android phone. Any phone, it works well. Further, Bubble and Bluecon, they are a bit difficult to source. Bluecon has had its own issues, and off late, I have heard that it's discontinued. That's what I've been hearing. But there are few people who do use Bluecon. So now once we convert this into a real-time CGMS, there is also an option of what we call remote monitoring. To remotely monitor our blood sugar values, we can set up a Night Scout account wherein the source code is available online. You just need to you just need to go to GitHub, use the source code. It's pretty easy. Anyone who wishes to make a Night Scout, they can reach out to me. I'll help them absolutely free of cost. Also, there is another option now With the Night Scout, there's something called Night Scout Pro. You pay a small amount, around 4,000 rupees annually, and the Night Scout Pro guys, they send across your Night Scout link to you with the small fees. So, but what happens with this? You can also remotely monitor your child's blood sugar levels sitting anywhere. But the catch is the phone has to be with the child, with the person who is using the sensor, and it needs to have an active internet connection. Otherwise, it won't work. It will only relay readings to the phone. With these devices, we also get access to alarms when our blood sugars are going low or high, so that timely action can be taken. Further, as Professor Ben illustrated beautifully with that slide, that the engine and the last bogie analogy, that's actually true. But from a user perspective, and how do we accommodate that? So we really encourage people to go in for a blood sugar value, blood BG check in case their blood sugar levels are below 70 or above 200, because we've observed that there might be differences. And particularly in times of a low sugar reading, it's very important to check it via glucometer, because it might be a false hypo as well. It could be a compression low as well. So please, we very we encourage a lot of people to rely more on the blood sugar readings as compared with the sensor readings when the sugar levels are showing a lot of fluctuations. This is just to ensure that you do not overtreat your hypo, or you do not overcorrect by going in by a false high reading or a false low reading. That's the best way to accommodate the gap. I'm on a DIY loop through the Medtronic 722. And off late, what I have started doing is I do check my sugar levels before meals twice a day. So this just ensures me at the back of my mind that my devices are working absolutely fine, and the loop algorithm is working. Otherwise, if the sensor readings are off, everything is decided by the loop, there are chances that I might end up into a bad hypoglycemia. Now, coming to the last important point, can we really extend the sensor? Yes, we have been successful through an app called Diabox, wherein we are able to extend the life of the sensor beyond 14 days. How do we do it? You can go on, every one of us has the app called Telegram. You can search the Diabox channel or Telegram, download the app, and each step is explained there. It's pretty easy to extend the sensor. Now, why do we highlight extending the sensor? Because particularly talking about it in the Indian context, extending the sensor provides affordability to most of us. It has bought devices like Libre Pro within the affordable range, wherein we can actually explain it to the people who need it the most, that you can go on to a CGM for a cost as low as 150 rupees a day. So with this practice, what we have observed is that yes, people have started using sensors more, and with the app extension, it's been a beautiful I would say help to the T1D community in India. And yes, both Libre and Libre Pro sensors can be extended. I've been actually been told to just keep the time, finish my talk as soon as possible. So I'd like to open the session for any questions over here. Any questions, please, most welcome.
Thank you, Mr. Harsh. They were very useful tips, and I'm sure people would really want to know more about all these things. So please put in your questions in the chat box, and as we await questions, would you take some time and also tell everyone about Libre View and Libre Link?
Yes. With Libre Link Up app, we do not need the reader now. We can also activate the sensor through the Libre Link app. And You just need to register yourself, and it's very easy. It takes hardly 2 minutes for you to activate the sensor. The Libre View app is primarily intended for the use by the doctor, wherein your doctor sends you an invite and you accept that and allow your physician, your treating doctor, an access to viewing your blood sugar levels remotely. And there is another app called Libre Link Up, with which you can also remotely monitor your blood sugar levels. But over in India right now, we only have Libre 1. So Libre 1 is not a real-time CGM. We need to flash our smartphone every time when we need to check our blood sugar levels.
Yeah, but with these apps, parents can also know because it is intermittently scanned. Whenever you scan, so if a child has the phone whenever the child scans or the teacher scans, parents do get an alert. So that's another important.
That's a big improvement, at least from having nothing to this is a big improvement which we have had.
Yes. So now with the Libre, you don't need a Night Scout. With the Libre Pro, you still need a Night Scout. I think the Libre Pro would also with the Libre Pro, you would still need a Night Scout. And another thing is,
we do need a Night Scout, and for people who are on the DIY loop, they'll always need a Night Scout unless we have Libre 2 over here.
Definitely. So how long can you extend the sensor?
Sir, I've extended it for as good as 10 days.
10 days, and both for the Libre and the Libre Pro.
Yes, sir.
They go for a little longer when you extend it with Diabox.
Sir, I am a bit wary about extending it beyond because of issues related to skin allergies and all that, particularly in kids.
Have you noticed any change in the accuracy when you extend?
No.
Okay, so that's what I wanted to highlight. So we are still waiting for questions. There are a lot of compliments, and please send some questions because it's a very important point. Yeah.
Thank you so much, Harsh. Fantastic. Appreciate it. Sorry, my voice is not good.
Okay. If there are no more questions, I would like to give it.
The session is recorded and it will be up on the YouTube soon. So if anybody has missed, they can watch on that also.
So the session has been even streamed on YouTube live, and it's available on the ISPAE ACES YouTube channel also for anybody who has missed the slides or the presentation.
There is a very important point raised by Professor Wheeler that we need to be mindful. Professor, would you like to take it up? Would you like to enlighten us more on this?
Oh, absolutely. I love what you're doing with trying to get more people onto these systems. And my comment isn't a criticism in any way, but just so people, I guess, whenever they're doing something different, that they're mindful of what they're doing, they fully understand what they're doing. If the algorithms do adjust for the day that you're in with your sensor. So day 1, for instance, in all sensors available on the market is quite considerably less accurate than, say, day 5 or day 6 or day 10 even. And so the internal algorithm adjusts for that. So if you restart a sensor, it's actually on day 15, but you'll be restarting it on the algorithm for day 1. So you just need to be mindful, unless you're using an app like Meow Meow or something like that, which in fact has its own algorithm for managing the data, because Libre does not give those companies access to its data. So it uses raw data to make its own adjustments. So there's quite a lot of magic that goes on in a sensor. There's an internal algorithm that adjusts everything. So for instance, when they go from Guardian 3 to Guardian 4, all of that is adjustment and algorithm within the transmitter. It has nothing to do with a sensor change. So it's in fact exactly the same sensor, Guardian 3 and Guardian 4. It's just the transmitter that's different.
Yeah. So we should all be mindful of that. So if there are no more questions, I would like to invite Dr. Ahila to please take over.
No, thank you very much, Zalak. Thank everyone.
Okay.
Yes, ma'am. Yes, ma'am. Thank you so much, Ahila ma'am. The idea behind the topic, expert selection of all the cases for ISPAE ACES meeting, everything is done by Ahila ma'am. Thank you so much. A special thanks and gratitude for our experts today. Professor Ben Wheeler to join all the way from New Zealand today, that too on Sunday. Also, thank you, Mr. Harsh Kohli, for always being so spontaneous and supportive for all the diabetes programs we do. Thank you to our moderator, Dr. Saurabh Uppal, for taking up this task so well. We appreciate the time and efforts to make this successful. Thank you, Mohana, for such an interesting case presentation. We also thank our team ISPAE. Thank you everyone for joining today on Sunday morning. Thank you RX Events. And till we meet again for the next ISPAE ACES, which will be in March. Everybody, please take care. Thank you again for joining.
Zalak, thank you. Enjoy your lion forest.
Thank you, ma'am. So sorry. Apologies for not being able to be there today properly. Like there is a lot of internet issues. That is why. So sorry.
Yeah, she's watching lions. Right. Thank you.
Thank
you all.
Thank you. Bye-bye.
Thank
Thank
so
you.
much.
Till next time.
Yeah, my voice is back.